Hello, and a warm welcome to everyone joining us today for our Understanding Cognitive Changes in Parkinson's, Supporting the Whole Person webinar. My name is Kat Kershaw, she, her, and I am an Education and Support Services Coordinator here at Parkinson's Society BC. And I am delighted to be gathered with you today on Zoom for this very important and informative topic. I'd like to start the session just by acknowledging that we're all gathered on traditional and ancestral and unceded territories of Indigenous people across British Columbia. We're very grateful to live, work, and learn on this land, and we honour the resilience, knowledge, and contributions of the Indigenous communities past and present. I'm very delighted today to introduce our presenter, Tricia Wallace. So Tricia is a registered clinical counsellor and a former nurse, and Tricia has extensive experience working with adults in the field of mental health, specialising on ageing, chronic conditions, drawing on her diverse background. Tricia recognises the importance of a strength-based, holistic approach to living with Parkinson's disease that includes emotional support, skill building for individuals and their families. I'm going to ask everyone if we could just hold questions till the end. There'll be an opportunity if you'd like to unmute yourself and ask Tricia directly. Or if you would prefer, please feel free to pop your questions in the chat, which you'll just find below in the toolbar below. And I can share those with Tricia. So without further ado, I will pass you over to Tricia and we'll get started.
Hello, everyone. Good morning. So glad you could join us. I'm just going to pop the talk up on the computer here, and then we can get started. Here we are. How's that looking, Kat?
It's good. It's a little bit far away. Oh, yeah, there we go. Perfect.
Is it okay?
Amazing.
Okay, great, great. If anyone knows me, they know computers are not my cup of tea. Anyway, welcome. So, yes, we're going to be talking about cognitive changes here, and the idea is going to be going through some information about cognitive changes and dementia as a concept, some assessment, and looking at the bigger picture. So that's the outline. What happens if you do have cognitive changes? What does that mean? Is it dementia? We'll talk about different types of dementia, and also how I'm going to spend more time talking about how Parkinson's does affect thinking and memory overall. And then at the end, talk a little bit more about some strategies that might be supportive for you. So let's get right into it. Mild cognitive impairment compared with dementia. Now, many of you may have heard that you have changes through some assessment, and you might have mild cognitive impairment. And this is kind of like an in-between stage. So we all have some changes in cognition over time with age. And mild cognitive impairment is a place between normal aging and some other changes that affect memory. There's usually some changes in language, some trouble with language, and also some changes in judgment. But they do not significantly impair your ability to do daily activities. They might get in the way here and there, but you find your way around. The prevalence of mild cognitive impairment is across studies in general is pretty hard to assess because it tends to be underreported. But there are studies suggesting with Parkinson's that about 30, maybe 40% of people with Parkinson's live with mild cognitive impairment. And some more recent studies have suggested that mild cognitive impairment doesn't progress to dementia. Okay? Dementia differs from mild cognitive impairment mostly. First of all, I want to say dementia is on quite a large spectrum, right? So even hearing the word dementia, oh my goodness, there's a lot of variability in how dementia shows up in our lives. And so we know that it's sort of on a continuum, but it is defined as being persistent, and it's a change, to loss in your brain capacity that causes big functional limitations in usually across multiple areas of life. We know people with Parkinson's have a higher risk for getting dementia about 10 years after the diagnosis. And that risk starts to rise more as the years progress. But there are many variables that influence that risk. So let's look at these areas of what are we assessing when we talk about cognitive capacity? There's a lot of areas, aren't there? Memory's a big one. How to attend, how to focus is connected with how well we can remember. Executive functioning is kind of getting the job done. How do we follow stepwise processes? How do we problem solve? Language and communication changes, orientation to time and place, but also the visual spatial abilities, which are about orientation to our bodies in space and things in space. Motor functioning is still part of it. Um, Judgment and reasoning. Social cognition is connected with judgment and reasoning. So social cognition is the capacity to sort of, some people say, read the room. It's like to be able to sense in to the impact that we have on other people, or some tone or some variables that indicate a message to us socially. And sometimes those changes affect the capacity to have insight into ourselves or into what might be happening. Personality and behavior can change over time, mood, perception, and thought content. Now, these last three are quite mutable, and there's lots of changes that can happen in Parkinson's. So we're not really going to talk too much about those last three because there's lots of variability across the diagnosis of Parkinson's, where mood, perception, and thought content can change. But if you have any questions about them, we can talk about them at the end of the session. Types of dementia. So there are many types of dementia. I'm just mentioning a few here, which are the most common or prevalent. Sometimes you'll see the title neurocognitive disorder. That's a diagnostic category that is sometimes used to describe dementias. Dementia is an umbrella term for changes in cognition and other conditions and diseases that affect cognition. Alzheimer's is the most common. Vascular dementia are the dementias that relate to blood flow in the brain and interruptions in those. Lewy body dementia, which we'll talk about more. Frontotemporal dementia as well, which is distinct from Lewy body. There's some crossover, but there's a variation in why there's changes in the brain between Lewy body dementia and frontotemporal dementia. So those are the four sort of most prevalent types of dementia. The last one is mixed dementia, and that doesn't show up as much, but that is usually a combination of two different types of dementia. And what we might see most often clinically is someone who's diagnosed with Alzheimer's who also might have vascular dementia symptoms as well. Lewy body, let's talk about Lewy body dementia, okay, compared with Parkinson's disease dementia. Now, I'm sure most of you have heard that a big part of what causes Parkinson's are some clumps of proteins, alpha-synuclein protein, which folds in a way it's not supposed to. And it creates these clumps and which interrupt sort of nerve pathways. Now, this difference between Lewy body dementia, which has those clumps, they're called Lewy bodies, and Parkinson's disease dementia, is that the clumps start to form in different parts of the brain between the two of them. So because of that, Lewy body dementia has the cognitive impairment first. So there's changes usually in problem solving and in the way that people modulate their emotions and impulsivity. And these things come first with Lewy body dementia. And there's usually sort of a visual component, so more hallucinations come quite quickly. And that's the first and primary symptom. And then the Parkinsonism, the motor stuff, follows that or is a lesser of an issue. With Parkinson's disease, the cognitive impairment arrives after the motor symptoms, right? So motor symptoms first, and then at least a year after diagnosis, but often, like I said, it's after 10 years or more, then the cognitive changes start to become more evident. So let's look at the criteria for assessment. These standardized tests that I'm sure many of us have already taken, the MoCA, the Montreal Cognitive Assessment, and the Mini Mental Status Exam, those are screening tools. And they will focus on some dimensions that we sort of already listed. And those tools help the clinician to figure out what areas are intact and what areas might be at risk for you. And so I really want to diffuse the fear and worry about getting these tests. They're a good way to take stock of what might be going on for you. But we know with mild cognitive impairment, there can be changes based on things like lack of sleep, stress, changes in your medications, or maybe having an off day or week. So these mild cognitive impairment might show up on MoCA tests and the MMSE, but you might even find that it's changeable. So some people's scores go up depending on how they're feeling and what's going on. So they do not diagnose dementia. Okay, they're a guide for practitioners to further assess what might be going on for you. With dementia, we know the cognitive decline is persistent, it's progressive, and it's significant, it's very concerning, and it can be sometimes more concerning for the people around the person living with Parkinson's or Parkinson's plus. But it's still concerning to people in your life, and it could also be very concerning, of course, to you as a person with Parkinson's. It's also not better explained by another disorder. Like I talked about earlier, like depression and mood, like anxiety and depression, they affect cognitive functioning. Okay? The cortical part of the brain kind of shuts down a little bit when we're anxious and also when we're depressed and we don't think clearly. Yeah? Also with delirium. So delirium is a medical experience. It can be typically it's sort of considered an urgent or emergent medical issue that starts to affect thinking. Yeah. So typically bladder infections, chest infections, actually any infection can cause delirium. And so we want to make sure that we're treating the delirium first to see if the medical condition first to see if that's affecting cognition. If there's a sudden onset of changes in cognition, typically, well, you want to get assessment as soon as possible. And then they're going to be looking for medical issues that might be underlying it. And that could also include some changes in vascular, the blood flow to the brain as well, just to make sure that you've checked off that these aren't issues that are affecting cognition. Independence as well is affected for in dementia, and it's decreased to the point where people can't think through what they need, and they get confused about where to go next and how to ask for things. That differs from accepting help or realizing that you need to depend on people more with Parkinson's in order to make good decisions to conserve your energy, for example. Yeah. One question that I think is really important here is, what are the goals for you as a person living with Parkinson's and Parkinson's plus? And what are the goals for your care partners and the team overall? So it's important to be able to listen to what other people might be telling you. If you're living with Parkinson's and people are sharing with you their concerns, it's really important to be able to work through that and to talk about that. The earlier we get on board and figure out what might be going on with changes in cognition, the better chance you have to work on some strategies and practices and maybe some medication that help the capacity of your brain over time. More variables with cognition that we want to look at, right? There's the variability of the symptoms of Parkinson's overall, right? They're going to change your capacity to think things through. There's the physical and emotional experiences. We've talked about stress, grief, right? There's lots of losses involved with Parkinson's. And those waves of grief that come over us can also affect our rhythms, our sleeping, our ability to focus. All of these things can have a big impact on cognition, but they'll change over time. There's some flexibility there. And brain changes themselves, right? And I'm talking about brain changes and capacity a lot because we do want to look at, yes, there are things that are changing in the brain, but there's also kind of an unending capacity for the brain to work through issues and to find a new way around some challenges. So we really want to draw on the capacity of the brain to keep on growing new connections between the neurons in order to help to cope with some and offset some limitations that might be happening. So cognitive capacity affected by Parkinson's. We're going to look at all of these areas and in more detail over the next few slides. That blue oval at the top is talking about attention. And it's when we're talking about memory, attention is a really important part of it. Yeah. And when we don't focus on things, the capacity to engage with information goes down. And if we don't engage with the information, we can't register it. We kind of can't go, okay, yep, I got it. And if we don't register it, it can't get into our memory. It can't get into our short-term memory. So engagement and focus is really important. And I want to stress an understanding of how hard it is to focus when you have Parkinson's. There's a lot going on. You're focusing on so many things consciously that used to be automatic. Your body in space, what's going on, symptoms. There's so many things that you have to focus on. So then when someone comes at you with a question or something they want you to remember, it's an extra thing you have to take in consciously. So some strategies around that might be, find a quieter place, sit down if you're standing up, stand up if you feel antsy and you need to move. So find a way, it's going to be individual for you to try and find a way to focus more effectively. And then we could just look at dimensions of memory. There's more than this, but these are the ones I thought might be important to sort of explore. So there's like immediate memory, right? There's sensory memory. There's sensations that come in to us, and they get processed in the brain through sensory pathways. We know that sensations and sensory experiences can get um, uh, interrupted, jammed up. The messaging can be unclear with Parkinson's at times, but it's a very short experience, right? It's 4 seconds. Right? Working memory, again, these are just the seconds, milliseconds, seconds. They're just general, different research says different things. But the working memory is temporary storage, right? And this is where we're kind of restoring and reusing the memory a little bit. Yeah, that's working memory. This is a capacity, a space where we can use the memory. And that only lasts 10 to 30 seconds. We used to say that working memory, we could hold about 7 things in our minds for a very short period of time. And recent studies are showing it's more like 4 items now. And I have a little theory that I think, remember when telephone numbers used to be 7 digits? I don't know. I haven't read any studies on it, but I'm curious about that. But anyway, I think they're saying 4 items is what people can remember. So it's not a whole heck of a lot. Short-term memory then is part of this immediate, after the 30 seconds, that short-term memory. Things go into the short-term memory, and again, it only lasts for 30 seconds. Some sources say 1 minute. It doesn't last for days, hours, or days. And then there's this distinction that it goes right from 30 seconds to long-term memory. So it's like 30 seconds or 30 years, that's the same category. But what that's kind of saying is the brain took it in. It's going somewhere. It's there. Now, we have challenges with how to access the stuff sometimes when it gets into our long-term memory. It's in a library, it's stored somewhere, but we can't remember what stack the book is in. So there's lots that goes on in terms of accessing and using our long-term memory. There's declarative memory, and there's distinctions here, and there's 2 ones that I just wanted to highlight. One is that there's like semantic memory. So that is where facts and concepts are remembered, and people with Parkinson's tend to remember facts and concepts, pretty well. Parkinson's doesn't get in the way a lot of the time. But episodic memories for people living with Parkinson's might be affected more. So episodes and events are remembered as well. So if you want to say, hey, I remember that time, well, why don't you just do what you did before? Remember when you did that and just walk through that, or, retrace your steps. Things we used to do to remember, help us with memory or in the past might not be effective or as effective in Parkinson's now. Procedural memory. So that's muscle memory, right? And that usually stays pretty well intact for most folks. Like we tie our shoes, play a piano song. That's kind of in our muscles, right? However, motor issues can get in the way from that, right? It makes the tasks more difficult. And that's very frustrating, especially if you're used to being able to do something really, really well. But there are some strategies, of course, to regain that with practice and figuring out maybe a different way to do things. Executive functioning. So executive functioning is, I'm clarifying that it's juggling multiple tasks, because no human can really multitask. Multitasking or juggling tasks is about us switching from one thing to the next to the next. And sometimes with Parkinson's, those switching processes get gummed up. And so switching is harder, and we can get stuck then on certain tasks, and focus has to be very different because that switching is harder. I'm sure most of you have heard do one thing at a time with Parkinson's, and that's actually a really good thing for most people to be focusing on, actually. I wanted to also highlight, so planning and problem solving are still part of executive functioning, and highlighting a little bit about what's going on in the brain is drawing attention to these loops, these cortical thalamic cortical loops, right? Or cortical striatal thalamic cortical loops. So what that's talking about is this looping from the cerebral cortex, that's sort of the high level processing conscious part of the brain. And it looks at, it's kind of integrating a lot of taking in, we're sort of being able to make decisions or have an impulse to do something with that. And then the striatum integrates. It's like an integration center, right? That's looking at the sensory motor data and the information and sort of that influences motivation, helps us make choices and sift through what's salient. And, it has to do with habit formation. All of those things are part of the striatal role. And then the thalamus is like a relay station that most sensory and motor signals have to go through. And then it loops back up to the cerebral cortex again. And so when that loop gets interrupted, there's going to be challenges with working things through. Right? And we see this across these loops, and there's other loops in the brain that are interrupted with Parkinson's like this. And we see, just looking at movement, language, reasoning, motivation, all of these elements of thinking are affected when these loops get affected. So it makes sense why there's challenges. Difficulty following steps and tasks. Flexibility of thinking decreases, and people might become a little bit more concrete, and they need different types of information to get the job done. And learning new things can also be challenging, motor learning and other types of learning. The visual spatial abilities, again, those loops are part of this, as they are with most elements of cognition and Parkinson's. So it's harder to estimate distance. It's depth perception is affected. It's harder to recognize like our bodies in space and also to engage with things in space. And it's also harder to copy things and draw and construct things that might have been quite easy to do before. That's very frustrating. And there's some, of course, some really great exercises that might support you. And for example, practice with constructing things or puzzles, or all the physiotherapy exercises and all the neurologic physio, the neurophysio can really be very helpful with these experiences to help to counter the changes. Language and communication. So again, loops are involved. They're associated with motor function as well, right? The production of language is super complex. There's thinking, there's motor function, there's the capacity to hear what's going on and to receive it in the brain and make sense of it, and then be able to share back what's going on. That's what expressive language is about. Salience is finding what's the most important thing to do or say at a certain time, in sequence, in context, and also motivation can be a part of communication. We know that there's changes in word finding, which can happen quite naturally with age as well, but it gets a little bit more intense, so it's hard to find the word. And what most people share with me is, if they try and find the word and they get geared up, then their motor symptoms start going and it makes it even harder to focus. What's it like to just let it go? What's it like to just set it aside? Or if people around us, or we can think, okay, it's used, you can name what the thing is used for. Try and name things that are involved around that item. And sometimes over time, that word will arrive to you. I know for me, sometimes it arrives hours later, but bing, it can arrive. Misnaming starts to increase as Parkinson's progresses. So things you might just hear yourself or others will hear you use a different word for an item than is the item. And there's a lots of different reasons for that. And some people it can sound like it. Sometimes it's associated with it in some way, or sometimes you're thinking about two or three things at once, and another term might come to you. There's fewer action verbs in people who use Parkinson's. So some studies have shown that using words like, um, walk or let's get this going, let's start this, let's make this happen. That's those types of action verbs that sort of are about uh, you know practice, organize, fix. These things start to become less discussed with people who live with Parkinson's. And again, that can be for different reasons, but it shows that there's going to be changes in communication of needs and even interests. There's going to be a different way through getting things done. There's difficulty interpreting information. Again, that can be short and sweet is typically better. Um, we know that if we have trouble, if anyone has trouble interpreting information, they might tend to move toward looking at the nonverbals a little bit more. So if there's some confusion with hearing what the content of the message is, they might notice a tone or a gesture or something nonverbal more. So this is a kind of an important focus on, if you are trying to get a message through, how can you be as calm as possible? How can you be as clear as possible and as rested? And so that your intent and the message comes through in a way that you want it to. There's less interest in people wanting to talk with Parkinson's. And, a lot of that can be psychological too, right? There's less motivation to engage. Doesn't mean people aren't interested. They just might not be talking as much. But there's also that feeling kind of deflated because people are speaking so quickly and it's really hard to be able to catch that information, process it, and then get the language into your mind and then get it out of your mouth. So there's some interesting strategies that might help, especially if people are around you, to slow things down or to say, hey, that reminds me of the time, and give you some more space to be able to share what you want to share in a social setting. Decreasing processing speeds as well is something that you want to just recognize, that sometimes people will say things they might not have said prior to Parkinson's, because the speed of recognizing, that's like social cognition, recognizing, oh, maybe this isn't the right time to talk about that. It's slower, so stuff comes out. And typically there's more impulsivity with Parkinson's, but especially as it progresses. And also just noticing changes in tone and prosody of speech. So people might misinterpret speech, tone, and sort of and also might not express the tone, and it might not connect, it might not link up with the content of what they're saying in the same way. So I also want to address a big shift here, but I do want to address the fear of, even as we've talked about all this stuff. I didn't put this at the beginning because it's like I've gone through a lot of stuff and a lot of possible changes. So first of all, I want to say, and we know that everyone has their own path with Parkinson's, and not everybody's going to get every change in cognition, right? Or deterioration in all the areas. Some of you might not get any at all or very little at all. Right? But there's still that fear. It's fear of the unknown, right? And the defenses that we feel, the worry, maybe the I don't want to think about this now, I don't want to go there, totally natural. You need to take some space from it. But I'm going to invite you to sort of to sense into, oh, okay, I am concerned about this. I am fearful about this. And that's okay. Spend some time with it. There's people you can speak with. who can support you. We can talk with you about it at Parkinson Society BC. Lots of people in your lives you may be able to reach out to. We know that uncertainty feeds fear. So focusing on specific things. What do you want to get done? What are you noticing is most affected? What areas of functioning do you want to improve? And then start to look at resources connected with a very specific thing that you want to work on. That's very different than thinking, oh my gosh, am I going to lose my mind? That's so general. That doesn't really give you any idea of where to go next and what to do. Loss as well is really important to explore, right? The importance of recognizing and sort of processing some of the challenges, the anguish, the frustration, the pain, the fear that comes with loss allows for that energy to go somewhere else. It allows for you to not hold on to things and to let some of that experience flow out of you. And when that happens, there's usually more space. There's more space to heal. There's more space to look at things differently. When we're fearful, our bodies will naturally start to look at what's going wrong and what's different. And we get locked into that. And when we talk about all deficits and all the tests and everything, that's kind of like what they're looking for. So it's really important to also come back to there's that, and there's also the capacity to look at growth and changes. Because like I said, the brain changes. It's growing all the time. Our entire being, our brain is changing and growing and trying to move in different directions. So this is about a health orientation, right? This is about looking at what's happening and what your capacity is, what's available for you. And health is about balance. It is not about the absence of disease. So we're really wanting to look at, okay, what are my needs now? How have things changed for me? Where do I want to go with this? And start to build capacity. And that means within yourselves, and that means people with Parkinson's and the people around you in your lives that are building capacity and learning and figuring things out, right? And also what can change in your context. How can you outsource some of the challenges or some of the supports or ideas for help? And you don't have to do it all yourself. You can outsource that to other people in your lives. Maintaining a sense of identity and agency, which is sort of the sense of the ability to do stuff, the ability to still move forward, is really important. So this is really about reorientation. And I'd like to highlight that actually we're kind of always evolving throughout our whole lives, right? We're changing. We're not our same self at different phases of our lives. Our experiences change us. But when we have a big experience, like a diagnosis and life with Parkinson's, for example, or a diagnosis, maybe there's dementia or some other changes, then there's this moment of, oh my gosh, am I going to lose myself? Right? Who am I now? And so this can be thought of as a loss on one hand, but also like an invitation. Like, okay, who am I to myself and others in this phase of my life? You know, and the gerontologist Gene Cohen talks a lot about that. You know, he did. He's passed away, but his studies were about looking at the phases of life and the stages of life up until the end of life, and talking about that a little differently. Aging is still filled with tons of change and growth. So who am I to myself and others? What have I accomplished in my life so far? What have I done? And how can I use that knowledge? How can I use those experiences to move me through this very challenging time now? And alternatively, maybe it's time to change some of the patterns I was using before. They might have worked really well for me in my past. They're actually not going to work well for me now. And other people in my life might be telling me that, but sometimes it's really hard to let go of some of the habits that we have from the past because they worked really well before. So it's important to ask yourself that and also to kind of take in the information that other people in your lives are giving you. One big one is pushing yourself until you're exhausted. You just go, 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 and then you got nothing left. Right? We know energy conservation is super important. It's important for physical stuff. It's also important for cognition. How are you going to communicate with other people? Might change. Look for new meaning. Loss is supported by being able to look for something other than and move towards something that's novel, right? How can you give back to the community? Maybe there's time to do that in a mentorship way or some way to be able to engage with other people differently. Are there any unresolved conflicts that you want to make right? Maybe you've been holding on to something, thinking, I always want to talk about this and I don't know how. And maybe this is a time to start exploring that a little bit more. Maybe returning to friends who you feel have drifted and there's this uncertainty. Should you like call that person you haven't talked with for 10 years or 15 years? Studies about regret show that it usually works out pretty good if you do try and reconnect with people that you might have drifted away from. And again, just that connection overall. Yourself, feel differently connected to yourself, other people, and people in your community or people around you. So, feeling protected and supported. If anyone knows me, they know I talk a lot about nervous system regulation and that sense of feeling that rest and digest place where we feel safe enough. We feel like a distinct difference where there's a sense of release or relief. And that opens up a lot of possibility in our nervous systems and in our capacity. We think better when we're in a state of rest and digest compared with the fight and flight freeze mode. Yeah. Any efforts we can do to open that space up are important. And there's exercises. People who know me, know I do a lot of sort of vagus nerve exercises. There's really great ways to pay attention to the moment and gather our energies for the moment. This doesn't mean you have to be a guru, climbing a mountain, sitting for half an hour. It does not. There's lots of ways to integrate that sense of rest into your everyday life. And you don't also have to sit still. You can move and be mindful and be present with yourself. So there's lots of strategies to move forward with that. It's really important to show curiosity as well. So the idea of moving away from judgment. And by the way, rest and digest helps us move away from that judgmental patterning in our brains. That can really help with having compassion, self-compassion, right? Being connected with yourself, realizing that you're feeling the feelings that you have and that you don't have to judge yourself. And that usually leads to us being more compassionate with other people, less judgmental. And guess what? The jobs get done better. When we're not having to work through a bunch of judgment, we have more energy to do the stuff we need to do. Planting seeds, right? We don't have to do everything all at once. We can be inspired by a small change that has a big effect over time. Keep up. Start somewhere. Focus, plan, start somewhere, and then practice and repeat it over and over again. The ability is typically going to come. You're going to grow new neural networks in your brain. The connections between the neurons in the brain are always trying to kind of reconnect with each other if they can. It's like the Wi-Fi signal that, your phone's always hunting and it has a whole bunch of Wi-Fi lists on there. Well, the neurons are they're trying to find their way around. And the more we plant seeds and try things, then the effect can be quite profound over time. try to discuss your needs. Find out, need statements are really hard. First of all, what am I needing? And then how can we share that with other people? And that can go both ways, right? It's the person living with Parkinson's and the people in your environment, the people who are with you. And being able to hear their needs is also really an important element moving forward. I've already talked about pain and loss, right? It's so important to be able to share that and have people be present with you in those with those experiences. And you don't have to stay there. You can get back on doing stuff, but making some times and maybe some rituals or a little bit of space to talk about this stuff can be really important. The last thing I want to talk about is the both and approach. And this is, of course, also involved with the nervous system regulation. And that is looking at sort of life's dialectics, the sort of dual awareness that we can hold in moments in our lives. Right? So we can be fearful and also hopeful, right? We can feel pain and also feel, some sense of excitement. These things can co-occur. So we really want to get away from the all or nothing thinking. That can happen when we're in an activated sort of sympathetic nervous system state. We're really so worried, and it's natural to go to all or nothing thinking. But we really want to try and broaden that out and balance that out, because balanced thinking can help balance in your life. And when we have balance, we feel more healthy. So it's super important to explore this dual awareness and the both and in moments in our lives.